we say pregnancy is like a stress test. So if at your stress, you have, for example, signs of dysfunctional metabolic health, or you have a change to your glucose control, or you develop high blood pressure, this is usually a window into risk later on, because with the stress of pregnancy, we saw some signs of metabolic health changes. And so once again, this is not, having a history of PCOS or having a history of gestational diabetes does not mean your future is written on the wall. What it means is you need to understand that this is a risk factor, and you need to be medically literate. And instead of having a blood test done kind of every 5-10 years, this is something to pay close attention to.
Welcome to Stronger by Design. I'm your host, Michelle MacDonald. Today's guest is Dr. Amy Louis-Bayliss, who's been an MD for almost 20 years, spending most of her career as an emergency medicine specialist, with 2 additional years of training in menopause and preventative health in Hamilton and Oakville. She is an advocate for women's healthy aging. Her interest in menopause and healthy aging stems from years of treating and managing disease in the ER once it was already too late. She also sits on the advisory board for the National Menopause Show, and she's passionate about educating women to build self-agency when it comes to disease prevention. Welcome to the show.
Thank you. I'm very excited to chat with you today.
Me too. We're going to cover 2 big pieces, and I want to dive right into it. The first one is what are the 6 metrics that change the trajectory as women are getting older, right? We're looking at key tests that women need to be doing, what they should be on the lookout for. Do you want to dive into that? Because I know you speak a lot about this, the importance of validating your health with measurable outcomes.
Yeah, I'm happy to speak to it. So I think as background and why I'm so passionate about discussing these 6 metrics is when it comes to aging, when it comes to your risk of disease, what women are surprised to hear is that the majority of our risk of disease is actually preventable. And so when I review these 6 metrics today, they really come from a place of you can actually do something about this. And some of this involves a relationship with a healthcare provider, involves having some blood work done, and some of it are metrics that you can test on your own. So the 6 metrics that I want to discuss today are cholesterol, your hemoglobin A1C, which is your average blood sugar, your blood pressure, results that you can gather from a DEXA body composition scan, VO2 max, and then just an understanding of how the menstrual cycle can be a clue to where your risk of disease lies and what to pay attention to.
I've never heard about that last one, so I'm interested to find out more about that. Let's take it from the top. I think we know the importance, or we feel that we know the importance of having great blood work when it comes to your blood lipids. But can you dive in deeper? So I want everyone to listen to this and walk away with clarity around what they need to be asking for in interpretations.
Okay, yeah, we'll start with cholesterol. So your cholesterol is actually very important. One of the big myths is that cholesterol in general is bad, but we actually need cholesterol. We need cholesterol for our brains to function properly, and all of our hormones are made of cholesterol. So estrogen, progesterone, testosterone, they're all made from cholesterol. However, because cholesterol is a fat, it cannot dissolve properly in our bloodstream, and so it needs to be packaged up so that it can travel to other parts of the body to help the body use it for hormones, for cell walls. And so when we look at these packaged molecules, some of the molecules are large, which if you've ever had your blood work done, looks like your HDL-C. And some of the packages for cholesterol are small, known as your LDL, or your low density lipoprotein cholesterol. And these small molecules are the molecules that we want to pay attention to. This is actually the number 1 risk factor, having elevation in LDL cholesterol for the development of plaque, or what we call atherosclerosis, which is the precursor to heart disease. And when you look at guidelines, most of the guidelines suggest if you check your cholesterol and it's normal, you do not need to have it tested for about 5 years. And even some guidelines suggest not testing it again for 10 years. However, when we talk to women and when we look at women, perimenopause and menopause actually play a critical role in an increase in our LDL cholesterol. In fact, you can see a rise of up to 15% just through the menopause transition. And so this is an important test to understand because we do know that the sooner you lower that LDL cholesterol, the greater the impact that it has on your risk of a future cardiac event, which would include a heart attack or could even include your risk of a stroke. As women, the menopause transition really is that female-specific risk for developing a change in the cholesterol. But the second piece is genetics. So I have many women that come to see me and they're like, how can this be? I'm eating really healthy. I'm doing all the right things. Why is my cholesterol going up? And really, genetics do play a significant role as well as just age. When it comes to managing your LDL cholesterol, we want to see it. I really like to aim for around the 30th to 40th percentile. This corresponds to an LDL-C, now this is Canadian units, of less than 3 millimoles per liter. And so the ways that you can help manage that from a lifestyle perspective is really you can look at a portfolio diet. This is a high fiber diet that helps bind your cholesterol that you're eating. And then we can talk about medications. So hormone therapy, if you take an oral estrogen, can be helpful in lowering cholesterol, as well as the use of a statin medication, probably being the most common medications that I discuss with patients.
Interesting. Oral estrogen versus transdermal. Can you explain that to the audience a little bit?
Yeah. So when you use oral estrogen is metabolized through the liver. So it's the impact that oral estrogen has on the liver. It actually changes the receptors on the liver that bind LDL cholesterol when you take estrogen orally. When you use estrogen from a transdermal perspective, it doesn't have an impact on the liver, so you won't see a change in LDL cholesterol.
This is important. I've never heard this before, and I'm sure people listening are in the same boat. And then, of course, there's that flag. Well, but what about oral estrogen and the contraindications for that? Do you want to talk about that a little bit?
Yeah. So when it comes to oral estrogen versus transdermal estrogen, this is when like personalized choice and a personalized discussion with your physician is important. So we do know that oral estrogen, once again, goes through the liver. And so you can see a benefit when it comes to cholesterol. And most of the trials that look at estrogen and its benefit on whether or not it's heart disease or dementia has been looking at oral estrogen use. However, when you do consume estrogen orally, because it goes through the liver, there's a slightly increased risk of developing gallstones and a slightly increased risk of developing a clot, which we do not see when we use transdermal estrogen. So once again, this is an important conversation. If you're under the age of 50, and you do not have risk factors for clot, you do not have concerns about gallstones, and your cholesterol is up, it may be a rational reason or a good enough reason to consider using an oral estrogen. Now, I will add that oral estrogen has gone head-to-head with statins in terms of benefit, and the statins did prevail over oral estrogen. So although oral estrogen is a tool in the toolbox, it does not replace the benefit of using a statin.
Okay, great. So, and did you want to mention anything about statins in women and female use at all?
I mean, just to say that they work, there's a huge myth that statins are bad for the brain because if you lower cholesterol, then there's no cholesterol for brain function. I will add that the brain actually can produce its own cholesterol and is not dependent on the liver. And so statins are not unsafe for the brain. And in fact, the new Lancet guidelines for preventing dementia actually suggest lowering cholesterol to an LDL of less than 3.3. And then the second is there's this whole idea that statins have not been studied appropriately in women. And it's true that statins are not represented. The statin trials do not represent women as well as they represent men, but we still have very, very strong evidence that statin use for lowering cholesterol is a benefit for women as well for preventing what we call MACE or major cardiovascular events.
Perfect. I know we were talking offline just about and with several other experts, speaking about, this concept that because we don't have sex-specific studies for women, it doesn't necessarily mean, or it doesn't mean that we should be looking towards animal studies to substantiate differences between pharmacological interventions for women versus men. Women have a lot more in common with men than they do with mice. So thank you for teasing that out. It's just important always to pull back that veil and just be honest about what the science can actually say and what's good and what's not good in this world of social media disinformation and emotionally charged messaging.
For sure.
That was a mouthful.
Okay. So we take on the next metric.
Okay. Yes. Let's keep going.
Okay. So let's talk about hemoglobin A1C. So hemoglobin A1C is a blood test. And basically, it looks like your blood molecule, which is your hemoglobin. And by looking at it, it gives us an estimate of what your average blood sugar has been over the last 3 months. So if you get a hemoglobin A1C, for example, 5.5, this would suggest that your average blood sugar, once again, in Canadian units, has sat around 5.5 for the last 3 months. Now, from a female-specific lens, there are some important modifiers to understand. So the health of your hemoglobin molecule is important to know how accurate that hemoglobin A1C is. And the reason why I say that is I see many, many women in perimenopause with very low iron. And if you have low iron, if you have a history of thalassemia, if you have any history that impacts the quality of your red cell, this test actually may not be as accurate and may not be the best estimate of your 3-month average blood sugar. So I will add that caveat. However, really, this is a marker of our metabolic health. And we know that our metabolic health is important for many reasons. The first is we know that our metabolic health is important for a risk for heart disease, for dementia. We know it's important for our kidneys, and we know it's important for our eyes. And we know that the development of type 2 diabetes is along a continuum. So we know that if you have a hemoglobin A1C of over 6.5, this would mean you had a diagnosis of type 2 diabetes. However, we should be talking about this if your hemoglobin A1C is 6.2, 6.3, 6.4. This doesn't just happen overnight. This is a gradual increase, and I really think the conversation needs to be happening earlier. We also know that your metabolic health is really important when it comes to cellular aging. So your ability to repair DNA, when we look at inflammation, this is a really important aspect as well. The best way of understanding what your average blood sugar is doing that hemoglobin A1C. However, if you do have low iron, then this is when a fasting glucose or a fasting blood sugar might be helpful, or using a continuous glucose monitor if there's confusion over the diagnosis. In terms of sex-specific risk for women, gestational diabetes actually doubles your risk of developing type 2 diabetes later on. So something to pay attention to if you have this history during pregnancy, and a history of polycystic ovarian syndrome. So PCOS inherently increases your risk for metabolic dysfunction as well.
Is this causative or is it more associative?
Polycystic ovarian syndrome. So it's a syndrome of dysfunctional or irregular ovulation, high androgens or like high testosterone levels, and then metabolic dysfunction. So it's a syndrome together that's not fully well understood, whether it's genetic, environmental, epigenetic. We're not sure, but it's a syndrome. We kind of see them together.
Okay, so if you have that, it's more likely that you are at higher risk of developing this. And the gestational diabetes as well, is that similar? It's associative, not like, oh, I had this, so therefore I'm going to have this?
We say pregnancy is like a stress test. So if at your stress, you have, for example, signs of dysfunctional metabolic health, or you have a change to your glucose control, or you develop high blood pressure, this is usually a window into risk later on, because with the stress of pregnancy, we saw some signs of metabolic health changes. And so once again, this is not, having a history of PCOS or having a history of gestational diabetes does not mean your future is written on the wall. What it means is you need to understand that this is a risk factor and you need to be medically literate. And instead of having a blood test done kind of every 5-10 years, this is something to pay close attention to.
Okay. So just to underline, this is something that we should be looking at having more frequently, scoring 6 or higher, or is it 6.2 and higher?
So I would say if you're starting to see, first of all, the trend's really important. So if you're starting to see, so say you had years and years where your hemoglobin A1C was 4.9, and then over the course of 2 to 3 years, it was creeping up to 5.5, 5.6. That's a really big change. For myself, I have really low iron. So my hemoglobin A1C sits around 5.7. But over the course of a few years, it stayed at 5.7. So really it's the trend that's more important. And this is where lifestyle actually can play a huge role. So we do know that the development of muscle mass, focusing on muscle mass can really improve glucose utilization and really improve that metabolic health piece.
Gotcha. Perfect. Thanks for clearing that up. And again, all of this is so helpful to people listening. I know I get asked all the time from my clients, like, what kind of test do I need to take in order to be on top of my health? I think women are a lot more interested, certainly the women that I work with, in optimizing versus being caught reacting. They want to optimize and be proactive. What about blood pressure? Let's talk about that. Hidden epidemic. What should we be monitoring there?
Yeah. So, I mean, elevated blood pressure is the most prevalent risk factor for heart disease. And we know that heart disease is the #1 cause of death for women. And to your point, this is a hidden epidemic. I mean, 20% of women between the ages of 25 to 45 have hypertension. After the age of 45, it goes up to almost 50%. And then once you're over the age of 65, your risk of hypertension is actually almost 70%. So this is something that we need to take a keep a close eye on. And I see so many women who go to the doctor, they have their blood pressure checked or they check it at home and it's borderline. And then it doesn't get checked again for like 1 or 2 years. If you're just checking your blood pressure and you're seeing numbers that are considered borderline, which would be, a blood pressure of over 130 as the top number or over 90 as the bottom number, this needs to be closely followed. And blood pressure, it goes up and down all the time. If you exercise, your blood pressure can go up or go down. If you're stressed, your blood pressure can go up. A salty meal can make your blood pressure go up. And so it's not really about what your blood pressure looks like in a single day. It's the trend of the blood pressure over time. And when it comes to testing our blood pressure, the actual testing of your blood pressure, it's a bit of a pain in the butt. You need to be sitting, you need to be rested and relaxed. First thing in the morning is usually the best time. And then you want to do one reading and then wait 5 minutes, do another reading, wait 5 minutes and do a third reading, and then take the average. That's the actual definition of how we make this diagnosis. But I personally, as a physician, and talking to every single woman I've ever worked with, no one's ever had that type of testing done in the physician's office. There are new wearables that are now looking at like multiple blood pressure tests during the day. So there's a wearable called High-Low. This does about 30 tests in about 24 hours. This needs to be calibrated to an actual blood pressure cuff, but can be really helpful if you're kind of have a borderline diagnosis or you're unsure or you're starting medications or using diet to try and bring your blood pressure down. At menopause, in terms of for women, estrogen helps with dilation of our blood vessels. So menopause does increase our stiffness, and that menopause transition can certainly increase our risk for developing high blood pressure. We know that if you're African American, your risk of high blood pressure is a little bit higher or significantly higher. And then the other piece to this is if you have a history of gestational hypertension or preeclampsia, once again, this puts you at increased risk for developing high blood pressure later on.
Okay, that's incredible. I'm going to go and start taking my blood pressure right now, especially because my stress levels keep going up, and while managing them, I don't want that functionality, right, or that perceived functionality to be masking the homework I need to be doing. And I'm sure the women that are listening to this are in that same boat, right? Because you can feel good, but that's not the same as measuring.
You feel good. You have no idea if it's high. Now, if you check your blood pressure, Michelle, and it's normal, your blood probably good to not check it again for 6 months, 8 months, a year. It's really when we're starting to see that borderline change, that systolic number of over 130, that diastolic number of 90, that starts to concern me because, like I said, there's so much borderline that gets left behind and doesn't get adequately managed. And it's important that you keep on top of it and understand what the trend is in terms of blood pressure.
Yeah, I think, and it's a great moment to interject here. A lot of times we can feel healthy, whether it's blood pressure or LDL, what's going on with our blood lipids, or our A1C. We can feel good, but the trends aren't favorable. And if we can use data to help inform decision making earlier on, then we're in a more proactive state rather than, as you said, your experience in the ER room was you're seeing people too late at this point, or not the ideal place to have these really massive positive health outcomes.
Yeah. And, anecdotally in my practice, I find that if you intervene earlier, now, whether that's through lifestyle intervention or medications, the body's response to improvement is so much more favorable. And women at our age are interested in 20-year outcomes, 30-year outcomes. And we don't really have the studies to support that. But we do understand what 10-year risk is. And so for women looking to be healthy for another 20, 30 years, these conversations really need to start in your 40s and early 50s.
Beautiful. And once again, these blood pressure tests, I've seen cuffs available in most pharmacies at this point, certainly here in Mexico where I am. I'm sure it's the same in Canada. They're not expensive. And you're saying take them in the morning, ideally rested, so you haven't had your triple espresso yet. And you want to do 3 distinct tests around 5 minutes apart, correct?
Exactly. You want to be seated. You need to have your arm out straight. There's multiple YouTube videos that are helpful. Hypertension Canada, you can check that out from Mexico or anywhere where you're listening from, has vetted blood pressure cuffs and videos on how to check your blood pressure as well.
Perfect. All right. That's 3 tests. Now we're on to the 4th one, DEXAs. Right? DEXAs. I love DEXAs. Body comp versus formal BMD. What each can and can't. Tell us. You want to talk about DEXA scans.
Yeah. So let's just take a step back and understand where I do think DEXA is changing the conversation. And really, it's when we look at how we've classically looked at health, and how we've classically looked at body composition and health has really been around this metric of BMI, right? Our body mass index. And we make these generalized statements of health versus non-health, obese versus non-obese based on these BMI metrics, which are really based on your height versus your body weight, and then gives you this BMI index. And when we do this, we don't actually consider body composition. So is someone who maybe weighs more or has a high BMI, they can actually be all muscle. It's actually not a reflection of their true health or whether or not they're obese. It's muscle mass that's actually making up the bulk of their weight, and in fact are healthier than someone who may be very, very thin, but does not have any muscle mass. So I think this idea of using BMI as a metric of health is starting to change. And we're starting to transition into two ways of looking at it. One would be the use of waist circumference. So this idea that as waist circumference gets bigger, it may be more of a risk of developing abdominal fat or fat around the organs of the body, which are inherently more inflammatory and a metric of health, or the idea of using a DEXA scan. So a DEXA scan is a very, very, very low radiation X-ray. It is so low that it's about the same amount as the background radiation you would have from spending a day outside and a sunny day. And what it does is it allows us to take a look at the individual and actually quantify of their body composition, how much of this is bone, how much is muscle, and how much is fat. And this can be a much better metric of understanding overall health. You could be very, very thin, but when we do a DEXA scan, it's actually suggestive of what we call sarcopenia, or low muscle mass, which could be actually reflective of a risk of frailty as you get older. And to the opposite, you could be at large in terms of BMI or higher on the BMI scale, but when we do the body composition test, actually you're quite adequately muscled, and there's no signs of fat or visceral fat that we would be concerned about in terms of risk for health. So this is a test that really gives us a true understanding of body composition, and it can be very inspiring and motivating for women, especially when it comes to putting on muscle. We'll get a quantity. It's called the relative skeletal muscle index. It looks at the amount of lean mass in the arms and the legs, and it can be a really great opportunity for a woman or a man to set goals for the next 6 months, for the next year, to put on more muscle. We quantify it by percentile. So are you in the 70th, the 50th, the 90th percentile? And what would an increase look like to get there? This is different, although it's the exact same machine that does bone mineral density for diagnosis of osteoporosis. How the machine is used is different. So when we do DEXA for body composition, it's a scan right through the body, and it gives us a whole bone mass. When we're doing this for the diagnosis of osteoporosis, the DEXA scan, although it's the same machine, it's zeroing in on the hip, it's zeroing in on the L spine, and it's zeroing in sometimes on the wrist to give a quantified number, which is called a T-score or a Z-score, depending on how old you are. And then you're using that to calculate what an individual's risk is for hip fracture. So it's a bit different. This is a focused, zoned in test looking at formal bone mineral density.
Do you, for women that are listening to this, would they need to go to a specific clinic to get BMD test versus the body fat muscle test, or is it just a matter of talking to the provider?
Yeah, no, that's an excellent question. So right now, at least in Canada, this is something you would be interested in, and as time goes on, these are getting cheaper to access, but I do acknowledge that this is not accessible to everyone. And this is where maybe waist circumference might be something else to consider if you're interested in body composition. But right now, at least in Canada, the ability to access a body composition DEXA would really be by doing a Google search and finding a clinic who has purchased one. However, for formal bone mineral density testing, if you meet criteria for this, this is an insurance-covered test, and this test is usually done at a facility that has a license to be able to do it. So this is a regulated test, at least on a provincial and federal level in Canada.
Why would it be regulated?
I think it's regulated because it's an OHIP covered service. And first of all, it's a quality assurance piece. And so whoever this is being funded for, the government's funding this, they want to be able to provide quality assurance in terms of, is there accuracy in the T-scores? Is there accuracy in the Z-scores? I think the other piece to this is the funding piece. So there's only so much money that's going towards formal bone mineral density scans a year, and that is divided by the licensed facilities.
Gotcha. If anyone's had that test done, there could be a large degree for human error if you don't have a qualified person running the machine. So, and that's important, right? If you're making a decision on your health protocols.
Yeah, absolutely. And for example, because the bone mineral, the body composition DEXA test, it only gives you a gross number, meaning like an overall weight for your bone mineral density. And I've seen women who have had normal numbers, quote unquote, come back for bone density, and then they actually have osteoporosis at the hip. So it's still important to understand what your personal risk is. And the way we calculate this is using something called a FRAX score, FRAX. This looks at personal risk. It looks at family history. And it gives you sort of a quantifiable number. And I think women should be starting to do this around age 50, because if you are at risk for osteoporosis, it doesn't really matter what that body composition test shows, although it can be reassuring, you should probably still have formal studying done. And then to your point, one of the criticisms of DEXA is there's inconsistencies. You can have inconsistencies from DEXA to DEXA from an error rate of anywhere between 2 and 4%. So if you, for example, are diagnosed with osteoporosis and you work really, really, really hard over the next year to try and improve bone mass and you repeat the DEXA, the improvement that you have may actually be lost in the DEXA scan from one to the other. So trying to stay at the same place, having it done at the same time of day can actually help reduce that user error and try and minimize that 2 to 4% user error that happens from DEXA scan to DEXA scan.
Great. So the Canadians that are listening to this, it's a little bit moot in terms of finding a qualified practitioner or, mechanic or the person provider with the DEXA scan, because it has to be in a certified or a regulated clinic or place, right? But in the States, and we have a lot of American listeners, most of my clients are American, it's a little bit more of an open market, I believe. I know that there's people getting DEXA scans for $60 here and there. So probably they'll need to do a bit more due diligence and just have that in mind, that there is an aspect of human error, especially around the bone mineral density test that or score that you're going to pull from your DEXA.
Agreed.
Yeah. Okay. We're just agreed on that. So perfect. And you said one thing very briefly, and I want to tease that out a little bit. You talked about, getting that body mass looked at and what you want to be alert to. This is probably going to apply more to those smaller or lower weight women. If you're not showing enough, or you're not in the right percentile for muscle mass. You talked about the projection of frailty in later years. Can you tease that out just a little bit more for the listeners?
For sure. So when you do a DEXA scan for body composition, like I said, the DEXA scan will calculate lean body mass. So and it can do fat, lean body mass, and then bone density. But included in that lean mass are your organs, like your lungs and your heart and your gut and your kidney are all included in that lean mass. And so the way they actually make the calculation is they remove the trunk and they only actually look at the arms and the legs to quantify muscle mass. And it does give you a numeric, like in weight, like a grams of how much lean mass you have. And as I said, we use that and then we look at percentiles compared to other women of the same age. Now, what this does not do is quantify the quality of that muscle. So you can still have significant strength. You can still have significant power and not have a high relative skeletal muscle index or like a high amount of muscle mass on DEXA. And conversely, it's the same. You may have a lot of muscle, but you may not have, once again, power, strength, balance. And so it really is, when we look at risk of falls, it really is considering a balance of both of them.
Perfect. I think that's just so important to underline. And again, just being a Gen Xer and growing up in the heroin chick era, where thin was in, it's hard not to associate being on, hitting a low number on the scale and being excited and thinking that means you're healthy. And we want to be aware that there could be risks of being underweight and gaining muscle and maintaining your muscle mass throughout your life cycle is becoming increasingly important to monitor for women.
Agreed. The other piece that just is important to understand, just to your point, is women often equate body composition to BMI, right? And we've been drilled down BMI healthy numbers for a very long time. 19 to 20 is considered nice and thin, and 21 to 25 is normal. And once you're under 25, over 25, you're overweight. And so people have really anchored onto these numbers. And when you do the body composition scan, it gives you a body fat percentage that most women are looking for a number that's the equivalent of BMI. And this is often often not the case. So when we look at the average healthy body of an individual going through a body composition DEXA scan under the age of 50, on average, we see a body fat percentage of around 30%. And so women will really anchor onto these numbers, whether it's, and as you get older, that goes up to 40%, these numbers of 30%, 40% body fat, and they anchor on it. They are upset. And so once again, prefacing that it's not the same as BMI, prefacing that this is healthy, and this is a healthy amount of fat and normal compared to your peers, is something that probably should be done beforehand, especially with women who you can perceive have been as women who have been self-critical and really groomed to think that smaller is better.
Beautiful. I just learned something there. So do not associate that DEXA scan body fat with BMI, right? We hear 30%, we think, oh, that's obese, right? And you're saying, no, don't do that.
BMI of 30%, but it's not. It's fat mass, and that's completely normal.
Completely normal. Thank you so much. See, there you go. I learn something every time I sit on these podcasts. Another thing I want to tease out, you mentioned, because I deal with this all the time with clients, you said why we want to look at this as a preventative scan. And I know a lot of feedback I'll get from clients when I say, can you get a DEXA scan? I usually I'm at requesting them to get it for bone mineral density, and it's usually gals that I suspect have been dieting for a long time, whether they're thin or not, or my clients that are more underweight for their height. I'll say, can you please get a DEXA scan? And I'll usually ask them to do that while they're in their late 40s, or if I've started working with them later in their early 50s, and they'll say, "Oh, well, it's not covered." I asked my doctor, and it's not covered by insurance. So, can you talk a little bit about how women could navigate that? How do they get that test done? You talked about a FRAX score. Is that something that they could, investigate family history and present something to a doctor? Can you talk a little bit about that?
Yeah, so most insurance plans aren't covering DEXA for body composition, but when it comes to DEXA for bone mineral density, this is probably a fight you'll need to bring to your family doctor. And I don't want to use the word fight, but when we look at the guidelines for diagnosing osteoporosis, they're very reactive, meaning that we want to use DEXA scan on a provincial, national, statewide level to look for who has osteoporosis and intervene. And so when you look at a lot of the guidelines don't even suggest considering this until you're over the age of 65. I think that's bananas. I think
I do too.
We shouldn't be looking for osteoporosis and then starting women on treatment. We should be using this as a conversation tool to say, if you're at risk of osteoporosis, what are our ways that we can intervene early to prevent that transition into osteoporosis? And so I think this conversation needs to happen around the age of 50. As I said, FRAX, F-R-A-X, it's a validated tool. It tells you whether or not you are at particular risk of developing osteoporosis compared to your peers. So do you have a smoking history? Do you drink more than 2 drinks of alcohol every day? Do you have a history of absorption problems like inflammatory bowel disease? Did you have to use steroids or other medications that may have had an impact on your bones when you were growing up? Have you ever had a personal risk of fracture or a personal fracture? Do you have a family history of osteoporosis? If you're petite, so you are small boned or like petite, less than BMI of 20, we also know that increases your risk for frailty. If you're Asian, that also increases your risk for osteoporosis. So if you meet this criteria, there is opportunity for you to take this information to your doctor and say, I would like to have a bone mineral density done now. And in the United States, hormone therapy is actually FDA approved for the prevention of osteoporosis. And so even to have the indication to be query use of hormone therapy to prevent osteoporosis, I think is a compelling enough reason to get a bone mineral density test done.
Beautiful. Thank you so much for summarizing that so succinctly. All right. This is going to be, I think, one of the most shared podcasts. And
I hope so.
We're already at 36 minutes. I want to spend the rest of the time talking about the last 2 tests, the VO2 max test, quick why it matters, and then cycle status, right? So let's cover those last 2 pieces.
Yeah, no problem. So a VO2 max is a test that looks at your cardiovascular fitness. So it is one of the best tools that we have to understand your future health span. So this is how long you live in good health, and actually one of our best tools to look at mortality risk. So even your risk of death as you get older. This is more powerful than looking at whether or not you smoked. It's more powerful than looking at whether or not you have a history of diabetes or high blood pressure. And what this test is, if you do this formally, is a sealed mask in which we are testing at 10 out of 10 exertion, how well do your lungs and your heart pump healthy oxygenated blood to your muscles. So what is the efficiency or the effectiveness of your heart and lung, your cardiopulmonary system at 10 out of 10 exertion? And it gives us a number in milliliters per kilogram weight per minute that we can actually plot. And VO2 max is a great predictor of health span, as I said, because we know what VO2 max will look like over time. Most of us lose about 10% of our VO2 max per decade as we get older. And VO2 max directly correlates with physical capability. So if you want to, at age 80, Michelle, be able to jog, we know you need to have a VO2 max of about over 30. If you want to be able to hike up stairs when you're 85, we know you need to have a VO2 max of at least 30. So we can actually do a VO2 max test on you, and then we can actually plot it on a graph and say, where you stand right now at your age, are you on the right trajectory for where you want the rest of your life to go, or should we be making some changes? Now, not everyone has access to a formal VO2 test in which you have the sealed mask. And formal VO2 testing is helpful in terms of if you're in sports, if you are really wanting to trend this over time. But there's actually ways that you can have an estimate of your VO2 max without doing the formal test. So one is most smartwatches will give you an estimate of your VO2 max. And the second is what's called a run test. So it's a 1.5-mile run as fast as your little feet can get you. And that time needs to be timed. And then you can actually go online to VO2 max 1.5-mile run test. You put in the time it took you to get it done, and it will actually give you an estimate of your VO2 max. And VO2 is one of those things you can't fake. There's a small genetic component, but it is a direct reflection of how much work you're doing right now for your heart and lung fitness. And the other best part of VO2 max is it's improvable. So it makes sense. If you put effort into increasing your speed to run 1.5 miles and your time goes down, that's going to improve your VO2 max. And so this is highly trainable. And so what an empowering piece of information to have. The best predictor of how well I'm going to age, also you have control over. So this is why I like discussing this point with my patients.
You said 30. Is that a relative to my age? I mean, I'm 54, can you talk about that a little bit?
Yeah. So when we go to VO2 max, we look at percentiles. So you can be in the bottom 25, 25 to 50, 50 to 75, and 75 and up. Certainly your VO2 max ranges are directly reflective of your age. For very optimized VO2 max, I usually say under the age of 40, you want to be over 40. From 40 to 50, I'm like, if you can match your age, you are in the top 75th percentile. And then once you're over the age of 50, I mean, really anything over 35, you're doing really well.
Okay, so that 35 refers to the percentile that you're landing in.
Yeah, so no, a 35 would be the quantifiable VO2 max. So 35 cc's per kilogram per minute is a VO2 max, gotcha. Which would be in the top 75th percentile for someone over the age of 50.
Wonderful. All right. So this is age dependent, these numbers. And then if you're hitting those numbers, you're looking at being able to be doing these things at, 85 years old.
Yeah. And usually when I'm talking to women, they've been doing cardio their whole lives. It's cardio, cardio, cardio. So convincing them to improve their cardio is not usually the challenge. And once again, going back to DEXA, this is where DEXA is really important because convincing women to start lifting weights for me is the bigger challenge than the cardiovascular piece. But sometimes they like gamifying and it's like helpful for instilling habits. And so using VO2 max, using improvement in VO2 max as a challenge to yourself, as a goal to set for the next year, can be really helpful for accountability and for setting goals and achieving it.
It's funny you said that. I don't have, and it's probably because of, the bias that I'm in as a strength coach. I don't have trouble getting gals to focus on lifting weights. I do have trouble, and I was discussing this with Dr. Lasola, I have trouble with cardio. They're like, and because there's that pendulum swing where cardio is going to kill your gains, and I don't have time for cardio, and then we end up not strategically navigating partitioning time and making it so that we can do it all, with the minimal effective dose that we can do of cardio to make sure that we're aging optimally, right? So I do actually have a little bit of a battle to fight there around cardio. And steps are not the same, right? It's like I'm doing my steps. Yeah. It's like that's that's not the same as training your heart, your pulmonary cardiovascular system under stress.
Yeah. And I mean, walking is great. You're getting out, you're moving, you're in the fresh air. There's nothing wrong with walking. And if you're walking, it's amazing. But you've already set a habit in place to get outside and move. To improve VO2 max, though, walking is not going to improve VO2 max. You need to elevate your heart because once again, it's how well your heart functions and your lungs functions at 10 out of 10 stress. And so if you're not giving your heart the opportunity to train under either like HIIT workouts or, taking small opportunities of time every week to really stress your heart, you won't see those improvements in VO2 max.
Great. And again, minimal effective dose for people that are time strapped. How do you do it all? I see those reels sometimes where there's like 50 things you have to do to like age well. And let's pull back on that narrative a little bit. There's like a little bit of things that you have to do. You can measure those things to track progress and trends. But it's good to be aware of what's available to you to really age well. The other thing that sorry, go ahead.
I was going to say, like for VO2 max, like even twice a week, 4 minutes.
It's not
like
much.
As hard as you can on, 4 minutes off twice in one session, and then repeat that twice a week. Like that's enough to make strides in VO2 max. So 16 minutes twice a week can do it.
And sorry, one more thing you said about the test, the sort of the at-home test, those people that don't have access to go to a clinic and do the full sealed oxygen test. You'd mentioned running. Now, again, my age group, my demographic, running for 1.5 miles. We've got, hip bursitis, knee issues. Is there any other test that they could do that's not high impact? Can they do an assault bike?
So I'm sure there's a bike one that you can do. If you have access to the Peloton app, Peloton does do an FTP test, a functional threshold potential test. That is how hard can you bike for 20 minutes. And that FTP test is also gives you a fairly accurate, for not doing the formal test, but can give you a VO2 max result as well. So that's an opportunity. And then, like I said, the key is really about improving VO2 max over time and paying attention if your VO2 max is going in the opposite direction. And so even using your smartwatch can be enough to kind of get you started and understand where you live in those buckets of 0 to 25th percentile, 25 to 50, 50 to 75, 75 and up. And if you Google VO2 max ranges for women and age range, there's many charts online that you can find to see where you land.
Perfect. Do you have any numbers in terms of the degree of error potentially with wearable tech?
Yeah, I mean, there is error. So we know it's about 10 to 15% compared to formal testing. Once again, if you're really curious and really want to be health optimized, then sure, go and get the formal test done. But really, it's improvement over time. And you can use your smartwatch. You can use the FTP test, the 1.5 mile run to track improvement. Usually recommend not retesting for a minimum of 6 months, just so you can truly see what direction you're heading in without that user error.
So maybe, go light, start with wearable tech. And then if you're in that borderline 10, 15%, if there was error and that brings you within borderline of not being optimized, then go and do do a run test or a Peloton test and kind of start triaging. And then, either you just say, well, you know what, I'm pretty close to being borderline. Let's start training this. Or, hey, I don't have time. I need to really know if I need to train this. And then you can find a clinic and go get a formal test. That could be like your decision matrix.
Yeah. And for the women that you see, like I said, we're having opposite conversations who don't want to do cardio, don't want to do their endurance testing. This can be a real wake up call if this is something that they need to improve, and also can be helpful for goal setting. And goal setting works really well with the kind of mindset of the women that you're seeing.
Perfect. One more test. Cycle status. Let's hit this. Why does it matter, right? Especially as we're getting older. Like, tell me about cycle status.
Yeah. So one of the things I don't think as society, or when we look at guidelines, when we look at how do we manage hypertension, how do we manage high blood pressure, how do we manage high cholesterol, when do we start thinking about intervening in terms of risk of disease, one of the things I don't think we do very well is consider female specific risk factors. And when we look at guidelines, a lot of the unique risk factors that women have compared to men are not integrated. And a lot of these risk factors are directly related to periods of time when our menstrual cycle changes. So, for example, we should go through puberty in which we have very irregular cycles. And then most of us will have a period of time leading up to about the age of 40 in which we have regular reproductive cycles. That predictive, every 28 days you get your period. It's predictable. You kind of know when it's going to come. If you have some symptoms leading up to it, it's kind of the same every single month. Then when we're going into our 40s, we start to experience perimenopause. Perimenopause is usually marked actually by quite a bit of hormonal chaos. And at the beginning, heavier periods, tender breasts, trouble sleeping, anxiety, periods closer together. And then we transition into periods spacing out, estrogen dropping, more symptoms related to low estrogen. So that's hot flashes, night sweats, low mood. You can start to have the joint pains, vaginal dryness. And then once it's been a year when you've had no period at all, for women in the United States, the average age is 52, in Canada, 51. Forever and a day after that, you are postmenopausal. And as women, that's how we spend 40% of our lives. And so understanding that that is sort of the menstrual cycle changes that we expect, and of course, not everyone is perfectly adapted to this, can allow us to sort of pay attention. So for example, if during your regular reproductive windows, you're having periods all over the place, they're happening every 2 to 3 months, or they're close together, this might be a sign to you that you may have polycystic ovarian syndrome, especially if you've maybe having some fertility issues. Once again, we talked about this earlier, this can be a window that your metabolic health may be at risk and something to pay attention to. If you go through menopause before the age of 40 or before the age of 45, this actually portends quite a bit of risk in terms of your risk for heart disease, your risk for dementia, your risk of osteoporosis. These are things to pay attention to. Once your period starts spacing out, we know that you're starting to see signs of low estrogen in the menopause transition. This is when we start to see changes in cholesterol, changes in blood pressure. This is when we may want to intervene in terms of that prevention of osteoporosis. This is a time to really start taking those health metrics we discussed seriously. And then once you've gone through the menopause transition, we don't expect you to have any bleeding again. So if after menopause you start having vaginal bleeding, this is a red flag and should be seen by your doctor. And so once again, understanding what these sort of expectations of the menstrual cycle are and how they can sort of give us a little bit of window in terms of my risk for disease is changing, I should pay attention to this, can be really helpful.
Brilliant. So it's less about a test, but it's an important metric. We want to think of your cycle as being a metric that you want to pay attention to, not just because you're irritated if something's irregular, but actually looking at it as a signal of your overall health, depending on the season of life that you're in. And this is huge. I think one thing that I've noticed as a coach, and I've been coaching since 2012, I'd say 95% of the time know more about a client's cycle than they do. because I track it because that affects data, right? So it's like, oh, I think you're in your, gals that are more symptomatic, whether it's, 4 to 5 pounds weight gain on the scale, it's water weight, hormonal water weight, or moodiness, fatigue. I've got to, be prepared potentially to adjust their training. Rare, but it happens. Or allowing me to interpret data or symptomology better. I have to track it. And I'll ask them to track it. I would say half the time, if I ask them to, they'll track it. But the other half, it's not really prioritized as an important metric. It surprises me, Amy. I don't know if you find that. Maybe you're a doctor, and so when you say to do something, it happens. But I think we as women, we aren't truly educated on the power of information that we can pull from our cycles.
Yeah, and I mean, like as a physician community, we're not very well, we're not medically literate when it comes to menstrual cycles and the impact they have on health. And so, the public is even less informed. And, I'll see women in early perimenopause whose iron is in the boots. Their hemoglobins, the amount of blood in their body are in the boots. And they're living with changing their pads 10 times a day. Their periods are, every 3 weeks, and it's become normalized to them. And so once again, understanding what quote unquote normal is, when it's worth checking or, at least seeing your provider for supports, I think is just so important.
Yeah. And then there's the, our providers educated. I'm thinking, and I don't want to go on a tangent because I've really maxed out on the time that you've given to me, and I appreciate it as well, Amy. But endometriosis, I'm thinking of one, friend of mine and also one of my coaches, and she's really been struggling with this for a couple of years. She's gone from provider to provider. She's now on deck with somebody who really specializes in this, but, it's been delays in getting in to see this person because their lineup is so huge. And you can imagine her iron levels and all of that are very suboptimized. And so it's challenging also to find a qualified provider that's really knowledgeable in cycles, and then even specialties like endometriosis.
I mean, absolutely. I mean, I can, just like you have women that you're seeing in your community. It's, I have so many women that I've seen who've been told they're crazy. It can't be true.
It's heartbreaking.
It's heartbreaking.
Or there's nothing you can do,
or just take the uterus out. I'm feeling hopeful. Yeah. I do feel hopeful. I do think too, yeah. I do think it's changing. I feel hopeful, and it's change is coming. It's going to be slow, but it's coming.
Yeah, and maybe faster than we think. It's great to see. Yeah. Again, with social media, there's pros and cons, but we're definitely seeing information spread like wildfire, and there's a lot of emotion. Yeah, there's a lot of emotion around prioritizing women's health now, and a lot of money and funding going towards. Hopefully, that's not just lip service, and it's really actually going to result in these great outcomes. Dr. Amy, thank you so much for being on the show. I can't wait to meet you at the menopause show. And we're gonna 2 weeks. A little bit less than, and we're going to get this. My intention is to get this out on the Tuesday, the 14th, before this drops. Before the show comes on. So. The people that are listening to this are going to get to listen to this. Hopefully, they're going to be inspired to come to your talk. When is your talk? Is it on Sunday?
On the Sunday, yeah.
Perfect.
I'm basically talking about health metrics.
Perfect.
So it's a little recap for them.
Good. And will you have some Q&A there, or will you be available for people to come up and meet you? I know you're we have a booth there, and then having done this before, the National Menopause Show,
I was funny. I was in the one in California on the weekend, and it was not the same. But this one, there's so many people there. They do a Q&A at the end. But what I did this year, because Amanda did it last year, Thebe did it, and was such a good idea, was I made notes for the talk. So women can scan this QR code and get a takeaway piece brilliant. That has a checklist for your 40s, your 50s, and 60s. So they can at least leave with a tangible item on what to do.
You got to come with your phone and scan that QR code when you're up on that platform. Thank you so much. Have a wonderful
I'm so glad
rest
we
of
can
your
do
day.
this, and I'm sorry about my migraine last week.
Oh, no, I need to apologize.
So I'm glad we could get this done.
I'll see you next week.
Yeah, looking forward to it.
Bye.
Take care.